Thank you. Great to be back up here and to see so many people, even on a Saturday. So I was asked to speak about the SYMPLICITY Hypertension 3 trial. Relevant funding is research funding from Medtronic, and I might say things that are off-label during the course of my talk or the discussion. So this was the design of the SYMPLICITY Hypertension 3 trial. It consisted of patients with uncontrolled/resistant hypertension. That is an office systolic blood pressure greater than 160 on at least 3 meds in 3 different classes. And one thing that wasn't part of the protocol, but I saw it on Dr. Sosembsky's slide, was spironolactone. We never published this data from SYMPLICITY Hypertension 3, but at the investigator meetings we encouraged spironolactone use. And in the patients where the investigators actually did that, it was amazing how much resistant hypertension vanished, especially in folks with obesity and resistant hypertension. So something to think about, even though we never published that aspect of it. But at any rate, patients had to be on at least 3 different classes at good doses, and then were randomized to a sham procedure or renal denervation, in this case using the SYMPLICITY Flex catheter. That's the predecessor catheter to the one that's approved right now for use in the US, which is the spiral catheter. And the primary endpoint was at 6 months, though there was follow-up that was planned for beyond that. I'll first just do a quick recap of the 6-month results, but then present the longer-term data. So the primary endpoint was published in New England Journal for this. For safety, was a performance goal. It was set based on a review of the literature and complication rates in renal artery stenting. So a performance goal of major adverse events of 9.8%. We actually observed 1.4%, which was significantly lower, so we were able to claim that the procedure was done safely. And you can see the actual event rates for major adverse events. They were low in both the sham and the renal denervation arm and not significantly different. So a safe procedure. But what about efficacy? Well, for the primary endpoint of office systolic blood pressure in blue, there was a significant reduction between 0 and 6 months in the renal denervation arm, but there was also a significant reduction in the sham-controlled arm in gray, such that the difference between those differences wasn't statistically significant in the overall trial. The same was true for 24-hour systolic blood pressure. Now, there were some different endpoints that were pre-specified, like nighttime systolic blood pressure, that were significantly reduced. There were subgroups that were pre-specified where there were significant benefits, but the overall trial didn't meet its primary endpoint. We teased apart why that might have been, and in some analyses, some of these are in the supplement to the New England Journal of Medicine paper, some are in the subsequent European Heart Journal paper. We saw close associations between the number of ablations performed and what appeared to be blood pressure and even heart rate response, such that the more ablations that were performed, the better. And along with that, we also saw that a circumferential pattern of ablation, and more of them, shown in gray, was better than not doing that. So it turned out that more ablations were better and circumferential ablations were better, which with that catheter took some effort. With the current catheter, sort of happens automatically. So these were lessons learned from SYMPLICITY Hypertension 3 that I think iteratively led to better catheter design and better patient selection. So that was the initial 6-month results in New England Journal of Medicine. Subsequently, the long-term results were published in The Lancet. I present this as a late breaker in the TCT. It was sort of peri-pandemic. I don't know necessarily that everyone in the field got to see the paper or the presentation, so I'll provide a recap here because I think it's worthwhile to know the full story if you're going to be doing these sorts of procedures. So here are basically the same patients, but we just followed them longer term. And at 6 months, crossover was allowed if the patient still met the inclusion criteria, that is, their blood pressure was still poorly controlled despite being on 3 medicines. Medication changes weren't supposed to be allowed up to 6 months, though after 6 months, medication changes were allowed. So this part of the trial is a bit different in the long-term follow-up. We do lose the pure randomization aspect, but just to let you know a little bit about the methods. So at 6 months, everybody gets unblinded, patients and physicians, after that primary endpoint ascertainment. And the sham control patients, as I just mentioned, were allowed to cross over and receive the renal denervation procedure if they continue to meet inclusion and not have any exclusion criteria. And for the control subjects who crossed over to denervation, then the last blinded 6-month blood pressure and medication data pre-crossover were imputed out to 3 years using LOCF, which means last observation carried forward. And any sort of protocol change that's notable, I'll just mention right now. There was an additional long-term 24-hour blood pressure and ambulatory blood pressure measurement that was added, though not all patients reconsented to that. And the follow-up was initially supposed to be 5 years, but in consultation with the FDA, it was reduced to 3 years. But by the time that happened, there were several patients that had already completed a follow-up past 3 years. So most of the data I'm going to present are 3-year data, but I'll show you some data for 4 and 5 years. Smaller number of patients, but there are some. And these are, in fact, what I'm going to present the final data from SYMPLICITY Hypertension 3. So again, patients randomized to renal denervation or sham control. At 6 months, there's an unblinding. The ones that initially got renal denervation, well, they're still in that arm. But in the sham control, some of the patients got crossed over, and some didn't get crossed over. And the main reason for not crossing over is because their blood pressure was no longer really elevated to the level that it would need to be able to cross over, which was a bit perplexing because those patients shouldn't have had any medication changes. Why did their blood pressure just go down? Probably had to do with better adherence. Even though it was a blinded sham control trial, of course, the patient is never truly blinded in blood pressure or cholesterol or other sorts of examinations because they can always check at home. So, what we think happened was that patients in the sham control probably were more adherent with their medicines than they had been pre-randomization, perhaps in part because there's a research nurse telling them, take your meds or you're going to have a stroke and other bad things will happen. So a bit of an artificial context of a clinical trial made them more adherent patients, we think, than was happening in real life. But at any rate, the majority of patients in the sham control arm did cross over, but a fair number didn't cross over. And here are the numbers sort of corroborating what I just said. In the renal denervation arm at baseline, you can see their blood pressures essentially 180 over 100. The patients that ended up crossing over at 6 months, blood pressures of essentially 180 over 100. But the patients randomized to sham who didn't cross over, blood pressures are at 6 months of 140-ish over 80-ish. So somehow or the other, their blood pressures came down. Like I said, I think it's likely that they became more adherent for a short period of time, for 6 months or so. The safety outcomes out to 36 months, even 48 months in these 3 arms, those initially getting renal denervation, those crossing over renal denervation, those not crossing over, low rates not significantly different. If you look at the composite safety endpoint, for example, about 15%, 14%, 14% in the 3 arms. So very safe procedure, no late emerging side effects or adverse events. In terms of number of medications prescribed, the number of medication classes wasn't different between the renal denervation and control arms, though the medication burden, if one looks at the daily cumulative doses and that sort of thing, was lower, in fact, significantly lower at 2 years and 3 years in those patients getting renal denervation. So if you just looked at the number of meds, you wouldn't see anything. If you looked at the burden of meds, you would see that there wasn't more, but in fact less use of medication in the renal denervation arm. So the results I'm going to show you now for the long-term results are despite the fact that there's actually greater intensity of medical treatment in the control arm. And here are the long-term results at 12 months. This is same color scheme, renal denervation in blue, control arm in gray, and at 24 months, 36 months, significant differences between the 2 arms. And at 4 and 5 years, here there weren't really a lot of control patients, so I'm just showing you the renal denervation blood pressure changes from baseline to the time of final follow-up. So it did seem like there was an effect here with respect to blood pressure lowering. That was systolic blood pressure in the office, same pattern for diastolic blood pressure in the office. This is ambulatory blood pressure at 12, 24, 36, and longer follow-up. Again, we see in the treated arm that there's a significant reduction, whereas in the control arms, there doesn't appear to be. So whatever was happening in that 6-month intense follow-up period in the sham patients seemed to disappear once they were back in real life. And here is the 24-hour diastolic blood pressure, same pattern as the systolic blood pressure, where it seems there are significant reductions in the denervation arm, but not in the control arm. These are data looking at the 24-hour systolic blood pressure control, baseline versus 36 months, renal denervation in blue, control in red. And you can see that at baseline in the dashed line versus 36 months, significant reductions across the full 24-hour day. At nighttime, there's a dip that we see here, which is normal and expected, but regardless of whether it's nighttime or daytime, significant differences in the renal denervation arm. But in the control arm, really no differences. One is looking at 24-hour control at this 36-month ambulatory blood pressure time point. Here's the distribution of blood pressures at baseline, at 6 months and 36 months in those that initially underwent renal denervation. And in this color scheme, red is bad, greater than 180, green is good, less than 140, everything else is in between. And you can see the shift from baseline to 6 months. There's more green and yellow, less red than here. And at 36 months, if anything, despite there being not more but less medication intensity, it seems like the blood pressure control continues to improve. So maybe some have said this is an effect of the procedure that actually increases over time. Could be other factors as well. This is what happened in the patients that crossed over to renal denervation at baseline. It's red at 6 months. They've not had a procedure. It's red. And now at 3 years, 2.5 years after having the procedure, we see a shift similar to what occurred with longer-term follow-up here. Lots more green and yellow. So in both those that initially underwent renal denervation and those that crossed over, similar patterns going from red to green. So limitations of looking at data this sort of way is that patients were unblinded at 6 months. However, the crossover patients' blood pressure after 6 months were imputed utilizing blinded 6-month values. Due to the crossover, the number of control patients at long-term follow-up was smaller, but we did a bunch of sensitivity analyses, a lot of fancy statistics in which all the missing data were imputed, and it showed consistent results to what I just showed you here. All of that's in the supplement to the Lancet. And finally, drug testing of urine and/or serum to assess patient adherence wasn't performed, but the patients were on the maximally tolerated doses of medicine. So let me just compare here hypertension 3 to the spiral hypertension on med. As I mentioned, what was used in hypertension 3 was a single electrode first-generation SYMPLICITY flex catheter. What's used in the spiral hypertension on med program and the off med program for that matter, and what's commercially approved is the SYMPLICITY spiral. So that gets around, I think, that issue of insufficient number of ablations and lack of circumferential ablations. As well, there's been a movement in the field to not treat just the main artery, but to go more distally as well, resulting in a lot more ablation. So whatever we saw in this long-term hypertension 3 follow-up, one might think would be even better with the currently approved commercially available catheter. And this indirect comparison, this non-randomized comparison of the SYMPLICITY Hypertension 3 catheter, the flex in blue versus the spiral hypertension one, in black, we see, if anything, larger reductions in blood pressure with the approved catheter. This is particularly apparent with the 24-hour systolic blood pressure. So to conclude then, in this final follow-up from the SYMPLICITY Hypertension 3 trial, which is still the largest and longest randomized controlled trial of renal denervation to date, we see that renal denervation was safe through this long-term follow-up. There were no weird late-emerging complications in terms of kidney dysfunction or renal artery stenosis or anything else people might have been worried about. And despite potential confounding factors, there were significant reductions seen after renal denervation versus control in both office and ambulatory blood pressure out to 3 years independent of medications. And I think these findings, especially when viewed in the totality of evidence for this catheter, but also other catheters, support that durable blood pressure reductions with radiofrequency renal artery denervation in the presence of lifestyle modification, maximal medical therapy are safely achievable. And I think this is the implication for clinical practice. Of course, maximize lifestyle modification, maximize meds to the extent it's tolerable, but then this is a new option that I think can benefit carefully selected patients. Thank you very much for your attention.